So in general, first of all, let me preface this.
Mm-hmm.
I remember 10, 15, 20 years ago, people talk about chemo and they still do as if it's this archaic thing and I can't wait to move beyond chemo. They're just giving chemo. That kind of has that negative symbol and it still carries that negative symbol. But what's amazed me about chemo is that negative vibe that had been thrown out there for so long. Well, in testicular cancer and now including in prostate cancer, it really has a dominant place. And can you explain that? What I mean by that is I'm so amazed at how 20 years later, it is such a dominant part of the conversation, including an aggressive disease, that what's your general recommendation now if someone's diagnosed or is on different drugs? I mean, is this as simple as anyone sitting down going, hey, I'm somewhere here in the spectrum of prostate cancer, do I qualify for chemo? Because chemo seems to be used in various points. I mean, what do you say in a consult like that?
Yeah. So let's just clarify first the term chemo or chemotherapy. If you really break it on down, is chemotherapy just describes any sort of drug therapy. Taking aspirin is chemotherapy. But in the realm of oncology, when we say chemotherapy, when a patient hears chemotherapy, they're really thinking about what we call cytotoxic chemotherapy. So basically, it's a drug that we give that non-specifically kills cells. Now, it kills more specifically rapidly growing cells. And the thought is that cancer grows more rapidly than normal cells do. So you get more focused toxicity against the cancer cell than you do against your own cells. But that also kind of explains why many of the toxicities we get, which are like GI-related toxicities, oral ulcers, those sorts of things, they have to do with areas that are rapidly growing cells, like hair loss, etc. Hair is very rapidly growing. So, that's what we're talking about when we're talking about chemotherapy. I think the reason chemotherapy had a bad name is because of this non-specificity. People like the idea, the approach of finding a gene defect and going after it.
Right.
And the field has changed a lot, not just prostate cancer, but a lot of diseases have changed a lot where we do have a lot more of these drugs. I think that it doesn't mean that we should forget about chemotherapy. Chemotherapy still has a strong role in these diseases. And in prostate cancer, as you mentioned, with some of the data with use of docetaxel early in metastatic hormone-sensitive prostate cancer, we can see an additional median at the middle, 1.5 to 2 year survival benefit. Whereas if you use it late for palliative effect, it's not nearly as dramatic. So there's still a role for chemotherapy. It's not always the end all be all. And there might be a day in the future where we're not using as much chemotherapy. And we certainly are getting smarter. We're understanding the biology better. We're developing newer, better drugs that are more targeted and focused. But it doesn't mean that we should forget about chemo.
So which chemo? There's 2 chemos FDA approved for prostate cancer at some point, right? There's Taxotere, right? Mm-hmm. And then there's Jevtana. Now, again, I'm just using trade names because patients and a lot of people understand trade names. The generic names makes people nuts.
Sure.
Me too. So Jevtana and Taxotere, is there any situation where you see either some kind of third one offered or Jevtana offered first? In other words, a lot of patients will say, hey, Jevtana, the second one seems to come with less side effects. Why don't we use that first? Why don't we use Taxotere? Can you explain which one they're using first, which one they're using second, and do we see possibly a third one or more in the future coming at us?
Yeah, so Jevtana, that's cabazitaxel, and Taxotere is docetaxel. So right now, docetaxel is being used in 2 clear disease settings. One is for a new metastatic disease that's still castration sensitive or hormone sensitive, testosterone lowering agent sensitive, and combined with the testosterone lowering agents. And that's where I said there's a dramatic survival benefit.
Yeah.
It can also be used for a metastatic, what we call castration resistant prostate cancer, where patients have received the testosterone lowering therapies and the disease has shown progression through that. And that's called metastatic castration resistant prostate cancer. In that situation, it also offers survival benefit, but it also offers pain palliative benefit. So in that situation, I tend to use the docetaxel a little later because the survival benefit is not as dramatic, and I'm not going to improve somebody's pain or quality of life if they're asymptomatic. Okay, so I tend to utilize it when they have more symptoms. Jevtana or cabazitaxel is now FDA approved after that. So for patients who have received the docetaxel Taxotere, and usually the patients have received a novel hormonal agent like abiraterone or enzalutamide, something like that as well. And that's where Jevtana is FDA approved. The reason Jevtana is not used first line is for a few reasons. When it first came out, it had a lot of toxicity. There was a 7.5% febrile neutropenia rate and a 4.9% toxic death rate. But that's because it was a new drug. We didn't quite know how to use it as well. We weren't using growth factors to prevent infections in the very first cycle right off the bat. And the dose was probably a bit high. It was 25 milligrams per meter squared. Subsequently, there's been a study that I mentioned in my talk that showed that 20 milligrams per meter squared works just as well for survival and has less toxicity. So that's what I use. And I think that the 25 is more toxic than docetaxel, but the 20 is less toxic than docetaxel. However, there was a study that compared the docetaxel and cabazitaxel, the Taxotere and the Jevtana, head to head, and it's called the Firstana study, and it didn't show benefit with cabazitaxel being better. Hence, that's the reason why people are still using Taxotere or docetaxel first and the Jevtana later after that. I think to answer your last question there in regards to other cytotoxic chemotherapies, I think the other situation where there's another cytotoxic chemotherapy that's going to get more attention is an old drug called Carboplatin. That's just a platinum chemotherapy. It induces double-strand DNA breaks for patients who have DNA repair deficiency, which I talked about with the PROfound study and the PARP inhibitors. These drugs cause breaks in both strands of the DNA. And if you also have a gene mutation in a DNA repair gene, those cancer cells just aren't able to repair that very well. And it's exquisitely seems sensitive and seems to work well in that patient population. And, you know, Heather Chang is one of our junior colleagues here. She's actually becoming an associate professor now, so not so junior anymore, but she's really led the charge in studying that in men with metastatic prostate cancer and DNA repair deficiency.
That's the third one that I hear so much about, the Carboplatin, right?
Mm-hmm.
You see that? I want to be optimistic that's going to get approved somewhere down the road on some level. Do you feel that way?
Well, I don't think it's a drug that's going to get approved, because to get approved requires that somebody actually
does it to a trial.
Right. Somebody actually puts a lot of money and resources into getting it through the FDA. I think it's a situation where we just need more data. It's not an expensive drug. It's an old drug that's available. It just will be repurposed in this setting. And I don't think that you always need to have a regulatory approval. So you have me on camera and on record saying that. Friends of the FDA, please don't be angry at me if you're listening. But
no, but there are people who clearly get it in oncology offices around the world, including in the United States, and they get responses to it.
Correct.
So you answered the question that I really wanted patients to understand, which is you have two of them, and you have one that some oncologists use now called Carbo. They call it Carbo. Mm-hmm. Latin, and some people get responses to it, which is pretty awesome. Mm-hmm. So that's great. So anything else in chemo that we didn't cover in terms of what's happening, that what people have to their beck and call?
I think those are the highlights right now. So I think you covered it pretty well.